guys, good evening. Welcome to Ophthalmology FMGE 2025 examination recall. Hi Bhuvan, I hope you are good enough, and we shall start with the ophthalmology discussion. This discussion is based on the recall questions, so please help me whatever language you want me to modify in the questions, in the options, images, and try to help me with the correct options as far as possible, so that we can come up with the as far as possible the right questions that were asked, right? So shall we start, guys? Looking at the question number 1. As far as possible, so looking at the question number 1. Now important thing in this examination was that all the important topics were asked. Like none of the question which came in ophthalmology was like that this was not an important topic, this was not, which is something which is regularly taught, or this is something that was not discussed, this is something which was not important. So all the questions were PYQs, PYTs, and more so I think that these questions are actually NEET PG PYQs. So if you see the previous year question papers of NEET PG 2018, 2019 as well as 20, you will find a number of questions which are coming repeats from this, and one of the questions which is very common, that is your Harvard Pitts wala image. That is exactly from your NEET PG 2024. That was our workbook image. So that makes me positive, that makes me feel better, because now you know the preparation that I am doing for the further papers is much more predictable. I know that what are the things I have to focus on, what are the things that I have to read on, and are we moving in the right direction, because I already know the topics which are most commonly asked, right? So one of the first question you can see where a patient who is having myopia, so we are having the history of myopia with flashes and floaters along with a deep anterior chamber. So what are flashes? Flashes means we have the flashes of the light, that is also called as the photopsia. This is also called as the photopsia. Floaters means the dark spots. These are the dark spots in front of the eye. So whenever you are getting the history of photopsia and floaters, we have dark spots in front of the eye, and that too in a myopic patient, you are always thinking about the rhegmatogenous retinal detachment. So this is one RD which has been asked so many times, and in your FMG PYQs also, if you remember, we had discussed a similar kind of question where they had also given the curtain-like effect. This was the additional thing, curtain-like effect. So whenever they are saying about curtain-like effect, they are telling you about photopsia, floaters, and sometimes they are also telling you about the B-scan ultrasound. On B-scan ultrasound, you will get the funnel-shaped RD. Funnel-shaped RD, which is on the B-scan ultrasound. Total funnel-shaped RD is there. That is also there. So the answer is very clear here, right? Now coming to the next question. Now this is another question that I always keep on repeating in the class, that you are going to get a question on acute red eye, a clinical scenario. And when we had done the session on the most expected questions for FMG examination, then also we had discussed this question on acute red eye, a clinical scenario, where the answer could be acute anterior uveitis also, and it could be acute congestive glaucoma also, either of them. Now here they are saying that it's a 60-year-old women, and so more than 50 years hai, female hai, with the sudden onset of pain and the blurring of vision. So we have sudden and painful diminution of vision, that means acute red eye. And whenever there is acute red eye, either you are thinking about acute anterior uveitis or acute congestive glaucoma. So already endophthalmitis and CRAO has been ruled out. Now you have to just see that is it acute anterior uveitis or it is acute congestive glaucoma. And you can see here that the cornea is hazy, anterior chamber is shallow, and pupil is mid dilated and fixed. Now there is a very clear cut demarcation. If I have acute anterior uveitis, I should have aqueous flare, I should have aqueous cells, KPs should be there, hypopyon should be there, iris nodules, posterior synecdoche, and above all miotic pupil. Above all we will have miotic pupil, which can lead to the deeper anterior chamber. While when we talk about acute congestive glaucoma, so it would be a female more than 50 years of age. We can have the walk striate, we can have colored halos, and here I will have dilated pupil with the shallow anterior chamber. So they have already given a female more than 50 years, they have given you a dilated pupil and anterior chamber is shallow. So here I will get the shallow anterior chamber, while in cases of uveitis it is deeper because of the smaller size of the pupil. So I think there is no point of confusion now. You are already sure that the answer here will be the acute anterior is not acute anterior uveitis, rather it is the acute congestive glaucoma. Is that clear, guys? Right, good to go. Then next question is a female patient who is coming with a painless ulcer and with a branching pattern in the cornea. So basically here we are talking about the corneal ulcers. It can be bacterial, fungal, acanthamoeba, or it can be viral, right? So fourth can be acanthamoeba also. Now whatever options they are giving you, they are saying that it's painless. Moment they say that it's painless, the bacterial and acanthamoeba will be ruled out, because bacterial ulcer is also painful, acanthamoebic ulcer is also painful, and in the bacterial, pain will be in proportion to the size of the ulcer. It will be in proportion to the size of ulcer, but acanthamoeba may pain is out of proportion. Here pain is out of proportion to the size of ulcer. Plus whenever I am saying that it's a acanthamoeba ulcer, here you will get the history of contact lenses. Here you are not getting branching pattern, rather a ring abscess. So you are having so many things due to which I am sure that this is not acanthamoeba, this is not bacterial ulcer. Now you have fungal and dendritic ulcer. Fungal ulcers are usually asymptomatic, but branching pattern is very much suggestive of the dendritic ulcers, where you can get the tree-like arborizing pattern is there, branching pattern is there, something like this. We have the tree-like arborizing pattern, and here we have got the knobs. So both knobs as well as floor, both are there. These are the knobs and this is the floor, right? Both are there. And whenever this kind of pattern is there, we have the knobs, that will be called as the true dendrites. Then that is called as the true dendrites, and true dendrites are characteristic of herpes simplex virus. While if I do not have these knobs, then it is pseudodendrites. And whenever I am talking about the pseudodendrites, then this is found in herpes zoster ophthalmicus, right? Now another important thing is the stains. So whenever I am talking about the dendritic ulcers, whenever we are talking about the dendritic ulcers, you have to remember that staining pattern. So floor and the knobs. Okay, floor ke liye we have fluorescein. We have the fluorescein stain, And for the knobs we have the rose Bengal. So F for F you can remember easily here, that F for fluorescein, F for fluor, and knobs ke liye we have rose Bengal. And another thing is that here steroids are contraindicated. Steroids are contraindicated. So whenever I get dendritic ulcers, I should not give steroids because they can enhance the formation of larger ulcers, which are called as the amoeboid ulcers, which are also called as the geographical ulcers. So we have to be very, very careful about the treatment of the dendritic ulcers, right? Then next question may patient is coming with a painful lid swelling and pus point is also seen. Now see, whenever I am talking about the lid swellings, these are the lid infections, right? And lid infections can be of two types. It can be acute infections also, and it can be chronic infections also. The acute infections are actually pustula. They will be showing you the pus point. They will be painful also, and these are called as the hodulums. They are called as hodulums. The hodulum can be external hodulum or it can be internal hodulum, okay? While chronic is called as the chalazion. So here they are showing you the pustular swelling, therefore we are talking about hodulum. And hodulums are present at the base of the Zeiss gland or the Moll gland. So I think they would have given only one thing, either Zeiss gland or the Moll gland. They would not give both. So I think according to the input that I got, I was not having the Moll gland in the question. I was having just the Zeiss gland. That is why we will go with this. But if both are given, then it's you know, not very simple to choose amongst the both, because both can be involved. That is why I think only one of the options would have been given. And whenever we are having the internal one or we are having chalazion, then it is the meibomian gland. Then it is the meibomian gland which is actually involved. Internal hodulum mein and chalazions mein it is a meibomian gland. This is also sebaceous gland, and hodulum mein Zeiss gland hai. This is also a sebaceous gland. So these are the infections that we are taking care when we are talking about the lid swellings. And a very important thing, whenever any person is having the recurrent lid infections, what are the things that you have to rule out? So there you have to rule out two things. Number one is the diabetes. If especially person is elderly, you should rule out diabetes. If the person is younger age group, then the refractive errors. So these are the two things that you should always take into consideration whenever the patient is having the recurrent lid infections, okay? Next question, 45-year-old patient is there who is coming and having the difficulty reacting to bright light. So bright light may he is not reacting, that means there is a absence of the light reflex. And light reflex is due to the pretectal nucleus. Near reflex is present. Near reflex present, and that means there is a presence of the accommodation reflex. So this is typically called as the ARP, which you can remember as accommodation reflex present, right? It is ARP, also called as the Argyll-Robertson pupil. This is called as Argyll-Robertson pupil at ARP, and which is taking place due to the bilateral lesion of pretectal nucleus. Example may, like I can have neurosyphilis. Example may we have neurosyphilis, where we have the lesions of pretectal nucleus and one reflex is present, one reflex is absent, but they are same in both the eyes. Like both eyes may light reflex absent, both eyes may accommodation reflex present. So this is actually called as the light near dissociation, and due to this light near dissociation you are getting isochoria. Same kind of reflexes found in both the eyes, therefore you will have isochoria which is present, right? The next question, This is also related to corneal ulcers. So this time 2 questions were there related to the corneal ulcers, as you can see, guys. A girl who is returning from picnic and she's complaining that she is having pain, and they are saying that they are not maintaining hygiene of the contact lenses. So previously also I told you that if they are giving you a history of contact lenses, then you have to go with the acanthamoeba. But the thing is that if Pseudomonas is not there, because you know Pseudomonas is the most common infection. If they are asking the most common infection in the contact lens users, most common infection in the contact lens users is Pseudomonas, while the most important risk factor which is there in the patients of acanthamoeba keratitis will be the usage of the contact lenses. So if both are given in the question, then your answer is Pseudomonas. If Pseudomonas is not there, then you have to go with the acanthamoeba. Okay. Then coming to the next question. So one important thing that I would like to say here, that there was questions which were PYQs, which were PYTs, but a very important thing is that they were offbeat from the trend in the way that they had not asked much of the cataract and glaucoma. So I would definitely say that they are moving towards the next pattern. Though next has not come literally, but practically they are shifting towards this. There are no one-liners, there are clinical scenarios and more questions from these subjects, as well as the questions are not from traditional cataract and glaucoma. They are moving towards neuro-ophtha, squint, nerve palsies, retina. So means when you know there was an era when you used to just mug up the lines and you used to pass. Now you won't be able to do your exam well with this, but yes, certainly if you are fine with your concepts, if you have done the important topics, then there will be no problem. So there is another question where the eye is down and out along with the ptosis. So this is a clear-cut case of the third nerve palsy, because ptosis is occurring due to LPS palsy. And if I talk about the third nerve, we should know that it is all three, SO4 and LR6, right? So all the extraocular muscles are actually supplied by third nerve except for SO4 and LR6. That means LPS is also supplied by third nerve, and we can have ptosis due to this. Plus down and out. Now only muscles which are working is superior oblique and the lateral rectus. So what are the actions superior oblique can do? Superior oblique ka main action is the intorsion. Then secondary action is the depression, while the tertiary action is abduction. So I will be able to do these three actions, while lateral rectus is doing only abduction. So that means our eye is able to do these actions only, and that is the reason that abduction is spared maximally, because both the muscles can do abduction and the eye will be in depression and abduction. So it will be down due to this, and it will be out. It will be down as well as out. So whenever you have down and out without thinking twice, you know that this eye is having third nerve palsy. Plus they have given ptosis also. So now you are 100% sure that this is the third nerve palsy only, right? Then posterior staphyloma. So posterior staphyloma, I think question was not posterior staphyloma, they were saying posterior curvature in the eyeball. So there was a posterior curvature in the eyeball, and options may they had given posterior staphyloma. Please correct me if I am wrong. And that is why the answer was posterior staphyloma. So whenever you are having the posterior ectasia in the eyeball, if this was the eyeball and we are having this posterior ectasia like this, this is called as the posterior staphyloma, posterior ectasia of the eyeball है posterior staphyloma. Other options में like we can I am not sure of the options. Please, if you can tell me, suggest the other options, that will help me. Retinitis pigmentosa is a degenerative condition, high myopia is a degenerative condition, or whatever options they had given. Coloboma, you know, is the absence of the tissue. Ocular trauma will not lead to the posterior ectasia. Staphyloma means it is the bunch of grapes like appearance. It is the bunch of grape like appearance that we are getting, and because it is occurring posteriorly in the eyeball, therefore we will call it as posterior bunch of grape like appearance, right? Then I do not know what was the exact question which was related to the Wilson's disease. Was there any question related to Wilson's disease, guys? Was it related to KF ring? You would have to help me in this. I do not know the exact question which came on the Wilson's disease, and you always know that it is actually the inborn error of the copper metabolism right, which is actually associated with the low levels of ceruloplasmin. They are associated with the low levels of ceruloplasmin, and that is why we can have copper deposition, and this copper deposition actually takes place in the alloy form. That is why we can have sunflower cataract. Can somebody help me? What was the question related to the Wilson's disease? Anybody who can remind me of this question? KF ring is the most common ocular association, and it can be associated with the liver disease as well as with the CNS disease also. You can have both. Liver disease may I can have KF ring in only 50 to 55%, while in the CNS disease we are having this in 90 to 95%. So I do not know the exact question, whether they asked about the KF ring, whether they asked about the cataract, ceruloplasmin, copper deposition in the alloy form. I think most probably they had asked about the KF ring, then this is the answer. Similarly, I do not know the question about the shield ulcers. What was the question related to shield ulcers, guys? Can somebody help me with the question? Shield ulcers. Shield ulcers are found in the VKC. VKC is the vernal keratoconjunctivitis, and we have a shield cataract also. Shield cataract is associated with the atopic dermatitis, while the shield ulcers are found in VKC, which is actually the most common allergic conjunctivitis. It is the most common allergic conjunctivitis where you are having itching complaint is very, very important. You can have a ropey discharge. We have itching, we have the ropey discharge. We can also have very, very typical cobblestone papillae, and also the Horner Trenta spots. Horner Trenta spots are there. These Horner Trenta spots are the collections of the eosinophils. These are the collections of the eosinophils. Cobblestone papillae hai, where you will have the polygonal raised areas like this. It can be hexagonal, pentagonal also. You have Horner Trenta spots, and in cornea basically we have the shield ulcers. Cornea may we will get the shield ulcers. And to complete the topic, what is the treatment of choice? That is the olopatadine. Treatment of choice is the olopatadine. Nobody told me, thank you so much, but nobody told me the question that was asked. Question भी बता दो क्या आया था? Then ये another question है which is actually Repeat from NEET PG 2024. There was a question on pituitary adenoma, which is compressing the optic chiasma. Chiasma means crossing over. So that means bilateral nasal fibers. Because nasal fibers are affected in both the eyes, so you will get bitemporal hemianopia. So every time you get one question, this I told you in the most expected questions also, that every time you will get at least one question from the visual pathway. When the temporal fibers are affected, it is binasal hemianopia. When the nasal fibers are affected, it is bitemporal hemianopia. Then pie in the sky, pie in the floor है. Then I won't bore you teaching all these things क्योंकि वो हम already कर चुके हैं ना, ये just recall है, लेकिन just recall में भी we can do that. और macular sparing हो सकता है when there is a lesion of visual cortex or the occipital lobe. तो I must say कि जो NEET PG पेपर भी देने वाले हैं on 3rd of August, please look at the session because all these topics are important, and you know topics always remain same whether you talk about INSET paper, NEET PG paper or the FMG paper. So it's worthwhile to go through the topics which have been asked in the FMG exam even before you are going for your NEET PG paper, right? Then again another question which came directly from the NEET PG 2024. NEET PG 2024, you can see these are actually the Herbert pits. And if you remember, I told you every time in the sessions and the class also that definitely you can get one question from trachoma, because trachoma has been eliminated very recently in 2024 NEET. In the year 2024. So definitely we can have this question. And second thing is that you know recently INSET paper has also taken place. So like there were so many questions from NEET PG 2024 in this FMG paper, I will say definitely look at the paper of INSET May 2025 also before going to the NEET PG 2025, because there are certain questions which can again come up directly or at least in the twisted language in the upcoming paper. So Herbert pits, pannus, as well as arts line, these all are found in the trachoma, while just now we have discussed ulnar trenta spots are found in the vernal keratoconjunctivitis. Then next question here, the light reflex they are showing. So basically this is a case of the Hirschberg corneal reflex test. This is Hirschberg corneal reflex test, and here we are checking the corneal reflex to find out the amount of squint. Like if it is in the center, then I would say it is 0 degree. If it is at the pupillary border, then I would say it's 15 degree. And if it is somewhere at the limbus, then it is 45 degree, like this. While if it is between these, then it would be something between 45 minus 15, that will be equal to 30 degree. So if you look at this question, you can see the reflex here, which is at the limbus. Limbus means 45 degree, will be into 2, that will be 90 prism diopter. So your answer to this question will be 90 prism diopter, right? Then what next? What kind of refractive error you can see here? So this is a repeat question from NEET PG 2023. Repeat hai, direct question hai. Even you know somebody had shared me the screenshot of this with on my workbook. The same image is also from our workbooks. Terms conoid hai. And the question was that how it is related. So this terms conoid is always related to the astigmatism. So answer is astigmatism, right? So this is, I think, a very clear-cut thing, and this again shows you the importance of doing the PYQs of NEET PG. So these are all the questions that we had got. If there is any other question that you can recall, anything that you would like to suggest, any other question, any other point, any other option, any other image you want to add on, then please let me know. Even if you are looking at this video after the live session, then I would request you to please give me the inputs related to any of the question discrepancy, so that we can come up with the right questions and the right options as far as possible for the next paper also, as well as next year examination aspirants. So thank you so much guys, and take care. अब ज़्यादा पैनिक की मत करना, रिलैक्स करो, and you have really worked hard, है ना, तो you deserve that rest. और बहुत ज़्यादा अपने आप पर हार्श मत हो. इट्स वेरी इंपॉर्टेंट टू लव योर सेल्फ. सेल्फ केयर इज़ नॉट पैम्परिंग, सेल्फ केयर इज़ नॉट ऑलवेज बैड, सेल्फ केयर इज़ इम्पॉर्टेंट. तो पेपर जैसा भी हुआ है उसके बाद अब रिलैक्स करना है, और फिर हमें ये सोचना है कि what we have to do. If we are expecting a good score, then very good, but even if you are not expecting this, है ना, हर वक्त स्टार्स हमारे साथ नहीं होते, कभी कभी वो दिन फेवरेबल नहीं होता, कभी कभी हमारी हेल्थ साथ नहीं देती है, या वट एवर रीजन, तो कोई बात नहीं. टेक अ गुड ब्रेक एंड देन कम बैक एंड बाउंस बैक. राइट, बाउंस बैक करना बहुत ज़रूरी है. अपने ऊपर विश्वास रखो एंड ट्रस्ट गॉड ऑल्सो. तो जो भी एक सुपर नेचुरल पावर है, जो भी ये सबको चलाता है ना, आप जिसको भी मानते हो, अपने गुरु को, अपने गॉड को, मेंटर्स को, तो ट्रस्ट इन देम एंड ट्रस्ट योरसेल्फ. एंड अगर इस बार आपका नहीं था तो नेक्स्ट टाइम आपका जरूर होगा. तो थैंक यू सो मच गाइज. हैप्पी ऑफ्थल्मोलॉजी.